Before I start and talk about this, I think important and but very common topic, I'm going to share with you my disclosures and mention that the presentation that I will be giving will be available to you, I think, as a recording, and you can also have access to the slide material. So if you miss something, you can always come back. And I will also mention that, this is a topic that I think is very relevant, not just to hematologists and internists, but a very wide array of clinicians. Perioperative management of anticoagulants or antiplatelet drugs touches pretty well every specialty. And in support of that premise, if you go to the up-to-date sort of resource, you'll see that the chapter on perioperative anticoagulation is one of the most widely viewed. It's in the top 0.6% of most widely viewed chapters. Now, I'd like to also bring to your attention an important resource that you have, and that is this the Evidence-Based Medicine 1 program, which is the textbook of internal medicine from McMaster University, where I reside. But what you might not know is that there is a Ukrainian edition for this textbook. And a lot of the things that I will be covering, in fact, pretty well everything that I will be covering, is also part of the McMaster textbook of internal medicine. So for your information, I'll leave this with you. You can see the Ukrainian edition can be available online or in paper form, and this is what the textbook looks like. So please consider this as a resource, not just for this presentation, but for all other topics relating to internal medicine. And if you want to just take out your phone and copy this address, you're more than welcome to. So with that, let's talk about what I hope to achieve in the next 45 minutes in terms of learning objectives. The first is that I want you to have an idea of how to manage various scenarios for patients who are on vitamin K antagonists. That's usually warfarin in North America. In other parts of the world, it might be acetylcrumarol. But we still are seeing a lot of patients who are taking vitamin K antagonists, especially for mechanical heart valves and other indications. More commonly, however, we may be seeing patients who are taking a DOAC or a direct oral anticoagulant. And how do we manage these patients who require an elective surgery? And finally, just to touch on a few things about antiplatelet drugs commonly used, and how do we manage these patients who are receiving these drugs and require an elective surgery. Before we get into the cases, I'd like to share with you a few building blocks, some foundational principles, if you will, on perioperative anticoagulant and antiplatelet management. What are these? The first is that when we see patients, we want to have an assessment of what is their baseline risk of thromboembolism or stroke. This is a very detailed table that provides an outline for clinicians based on the indication for anticoagulation, whether it's a mechanical heart valve, atrial fibrillation, or venous thromboembolism, and classifies patients accordingly, based on their risk for stroke or thromboembolism. So that may help you in terms of determining, how high is that risk for thrombosis, and in particular, for patients who are on a vitamin K antagonist, do I need to bridge them with a low molecular weight heparin? So we'll come back to this a little bit later. The other part, of course, is estimating the patient's risk for bleeding, which is driven mainly by the surgery or the procedure that they are having, because that helps us determine, when to stop anticoagulation, when to resume it, and of course, one has to be careful in situations, for example, patients at high bleeding risk who are receiving bridging anticoagulation. Both of these are empiric. They have not been sort of validated prospectively, but they provide a starting point. And these are two important foundational steps when you're assessing a patient on an anticoagulant or an antiplatelet drug who needs an elective surgery. I should also point out, if there are anesthesiologists in the audience, that any procedure that involves an epidural injection or any surgery with neuraxial anesthesia automatically is considered a high risk for procedures. And we're going to focus a little bit about that because these patients deserve special attention. The other learning point or building block is for clinicians to have a basic knowledge of some of the pharmacokinetic or PK or in some of the pharmacodynamic properties of anticoagulants. Why is this important? Perioperatively, because we need to know how fast drugs get out of the body if we stop them before a procedure or surgery, and as importantly, we need to know how quickly they act after we resume them. So we see that the elimination half-life of the DOACs is considerably less than warfarin or other agents. And this helps us determine how long we have to stop these drugs so that the effect is eliminated prior to the surgery. Equally important is the onset of action. You'll see that the DOACs act very quickly. Their peak action is within 1 to 3 hours after oral intake, and therefore one has to be careful about resuming them, especially after a high bleeding risk surgery. And then I just want to mention more for your information about the antiplatelet drugs. We have to consider them as not all the same. Aspirin and clopidogrel, which are widely used, are irreversible antiplatelet drugs. So they take at least 7 days, 5 to 7 days for the antiplatelet effect to be restored after they are stopped. On the other hand, ticagrelor is a partially reversible antiplatelet drug, so we only need lesser time, so maybe 4 to 5 days for the antiplatelet effect to be restored after they are interrupted. So a few basic principles, and there's one more, but I want you to think about what that last one might be, and we'll come back to that a little bit later. So let's start with a typical case of a patient that I would see in my clinic. This is a male with a mechanical heart valve on warfarin. It's a mitral valve, and they also take aspirin, and they need a lumbar deep nerve block procedure, let's say next Friday in the morning. As a clinician, you will be asked the following questions. When do I interrupt the warfarin? 4, 5, or 6 days before the surgery? After I interrupt, do I need to use bridging, typically with LMWH? That means low molecular weight heparin, as you know. And if I do bridge, how will I do it? Can you walk me through the procedure for bridging in this type of patient? So the primary question that is asked and the research is focused on is, do I need to bridge this patient with low molecular weight heparin? And if we consider what the guidelines say, this is from the American College of Chest Physicians that was published, just a couple of years ago. They indicate that in patients on a vitamin K antagonist with a mechanical heart valve having an elective surgery, just like the case, we suggest against heparin bridging. This is a conditional or weak recommendation. Other recommendations regarding bridging in patients with atrial fibrillation are similar. We recommend against bridging in patients taking a vitamin K antagonist for atrial fibrillation. This is a strong recommendation, though. And then in a minority of patients taking a vitamin K antagonist for venous thromboembolism, we also suggest against bridging. Now, you might be thinking, my goodness, did I hear you right? Jim, that you're not going to be bridging patients with mechanical heart valves? Why not? Well, let me take you behind the scenes a little bit and talk to you about what the panel discussions were around this when the guidelines were developed. The first point is that when you look at the totality, all of the evidence about bridging in patients taking warfarin, let's say, that it does not appear to reduce arterial thromboembolism, such as stroke, but clearly and consistently increases bleeding. Secondly, when we suggest not to bridge patients, that is kind of a starting point. We want to have that default option as not to bridge. But of course, if that patient has risk factors, for example, if they have a mitral valve, well, that is considered a higher risk group. And you can refer to the table I showed you earlier. And in my practice, I would bridge this type of patients. There are some patients with an aortic valve who also would be considered high risk and would be bridged. But there are also many patients with aortic valves who probably do not need to be bridged. So the guideline, even though it says suggesting against bridging for mechanical heart valves, has qualifying remarks. So as you can see there, that in selected high-risk patients, bridging is suggested if they have a mechanical heart valve. And the same applies for patients with atrial fibrillation or venous thromboembolism. If they are considered at high risk for thromboembolism, then heparin bridging is suggested. Again, the classification is based on the table I showed you earlier. So it kind of makes us want to think that not everybody should be managed the same, but the starting point would be we're not bridging, and then we move the needle the other direction toward bridging if we think they are at high risk. And that is because the evidence that we have does not indicate that bridging prevents or reduces stroke and thromboembolism, but we know consistently that it increases bleeding risk. Now, the other part that you'll be asked to do is that, let's say you are going to bridge this patient, and that's what I would do for this patient with a mechanical mitral valve, how to do it safely. We don't want to cause bleeding because if bleeding occurs, especially in a perioperative setting, it may lead to reoperation. It may lead to delays in resuming anticoagulation, which in turn may increase patients' risk for thrombosis and stroke. So we want to do it carefully. There are protocols that are available, such for managing patients before the surgery. So the day before the surgery, we reduce the bridging dose by 50%. After the surgery, we can start the warfarin the evening, but remember, that takes several days to start working. So it's not going to work right away. But if we start bridging after the surgery, we want to do it very carefully, especially if somebody is at high risk for bleeding. So I would wait in this patient because they're having a high bleed risk procedure. I would wait at least 48 hours, and in some cases, 72 hours. Or in other clinical scenarios, let's say somebody having intracranial or intraspinal surgery, I don't even give them a full dose bridging. I will just give a low dose regimen of low molecular weight heparin. So you want to tailor the management of bridging before and after the surgery according to the individual patient characteristics. Now, a little bit about what the future holds in this area. There is some emerging research actually that supports the premise that maybe we don't need to bridge a lot of the mechanical heart valve patients anyway. We're not quite there yet, but from this meta-analysis, you will see that the results show bridging associated with an increased risk for bleeding, about 1.8-fold. We know this, but also you'll see that it was not associated with a reduction in thromboembolism. And in this study, numerically, it caused more, was associated with a greater risk for thromboembolism and stroke. But we need well-designed trials before we can make definitive decisions about bridging in mechanical heart valves. And as I mentioned, in my practice and many others, we continue to bridge many patients, especially with mechanical mitral valves. Here's another recent study that I will share with you that was just published not that long ago. That was a cohort study involving over 500 patients, but only with a mechanical aortic valve. And we looked at different outcomes according to whether patients received bridging or no bridging. And the results might surprise you a little bit in that the study found, well, first of all, there was more bleeding in the patients who had bridging. Okay, that part is not very surprising. But there was no difference in rates of thromboembolism in the bridged and no bridging groups. So I think this leads to the need for a larger study to confirm these results and maybe expand upon them. So a little bit of peek into the future. And then the final point is that in some countries, they're using these newer mechanical heart valves called Onyx valves, which are thought to be less thrombogenic. But in the short term, these are not treated any differently than patients with other types of mechanical heart valves. Even if they are considered less thrombogenic, we still would approach them in the same way as we do other type of valve patients. Let's move now from the vitamin K antagonists to the more commonly used direct oral anticoagulants. And here's a patient with atrial fibrillation taking a apixaban, a commonly used DOAC, with a number of comorbidities, and is scheduled for major surgery with a spinal anesthetic. Again, let's say a week or this coming Friday. So the questions you are going to be asked here, once again, when do I interrupt the apixaban safely? Is it 2, 3, or even 5 days before the surgery, similar to what I would have done with warfarin? If I interrupt for a little bit longer time, do I need to use bridging with low molecular heparin? And thirdly, do I need to check a DOAC level to measure the anticoagulant effect of the apixaban the day before the surgery? Sometimes we might check the INR test in patients taking warfarin the day before surgery. Should we do the same with the DOACs? So let's explore this a little bit further. And the main question here, though, is when do you stop and when do you resume anticoagulants? And this patient had, as I said, an embolic stroke 2 years ago. So does that change our management? This is the approach, again, provided from the American College of Chest Physicians guidelines that looks at management according to the direct oral anticoagulant, whether apixaban, dabigatran, edoxaban, or rivaroxaban, and according to the risk for bleeding, whether high risk or low to moderate risk. You'll see that thromboembolism is not as important here because we're using very short periods of interruption. It's not like with warfarin where we stop for 5 days and it takes another 5 or 10 days for the warfarin effect to resume. With the DOAC, they have a rapid offset of action and an even more rapid onset of action. So bridging therapy to mitigate the risk for thromboembolism is not really important in this situation. Our patient would be considered at high risk, so they would skip 2 full days of their apixaban and maybe resume it on day 2 to 3. So very similar to what we do with our bridging patients. Remember, the DOACs act very quickly. So it's like giving a patient an injection of heparin. You have to be careful about doing it and avoiding doing it too soon after the surgery. So 2 days off before and at least a couple of days off after the surgery. These are the recommendations for the European Society of Cardiology guidelines, and you'll see they're pretty similar overall. And in terms of their recommendations, the wording is a little bit different. But you'll see here in the picture, it's very similar. So our patient at high risk for bleeding would interrupt the DOAC for 2 full days, as you see there. And then more recently, guidelines from the American College of Cardiology offer very similar recommendations. Once again, it's the same kind of table, looking at the DOAC type, the risk for bleeding. And here's our patient at high risk for bleeding on apixaban, and they're interrupting for 2 days, full days before, and 2 to 3 days after the procedure. Now, if you're an anesthesiologist, you may be also looking to guidelines from anesthesia societies. And what are these? Well, there's the American Society of Regional Anesthesia and its European counterpart, the European Society of Regional Anesthesia, and they've recently published some guidelines on the same issue. So what do they say? Is it similar or different than the other guidelines that I've told you? And these are focusing specifically on patients having neuraxial procedures, which come with a small, but very important risk of epidural hematoma that may be rare, but is potentially catastrophic. So anesthesiologists want to be very careful about stopping, and resuming anticoagulants in patients having neuraxial procedures. So their recommendation is that in patients who are receiving, in this case, a higher dose of apixaban, 5 milligrams twice daily, we recommend at least 72 hours discontinuation. And they also suggest measuring the apixaban level so that it is less than 30 nanograms per ml. And you're wondering, well, what does that mean? I didn't even know you could measure an apixaban level, and let alone try to interpret a level such as less than 30 nanograms per ml. So let's dive into that a little bit. Now, I will tell you that the ASRA guidelines are more conservative in a manner of speaking, that they allow longer intervals for interruption. And that is because their interpretation of the half-life of these drugs, and I'm using apixaban as an example, is longer than the half-life that we tend to use in practice, which is based on the product monograph and based on the other clinical studies. So there's a bit of a disconnect there because they're assuming longer half-lives for these drugs and therefore longer periods of interruption. And you're probably thinking at this point, well, Jim, if the anesthesia guidelines say 3 days interruption, you're saying 2 days interruption. Why is this such a big deal? And why are you making a big fuss about this? The American College of Chest Physician recommendation, and echoed by other societies' recommendations for 2 days of interruption, is based on available evidence. So we don't really have any clinical data on 3 days interruption. And this is largely expert opinion driven and based on studies that were done looking at the half-life of apixaban, but in healthy volunteers using very high doses. So these were not based on clinical data. So we don't have any clinical data on the ASRA recommended approach. And the guidelines have to make recommendations based on available evidence. So that's the first point. The second point is, if you consider 2 days interruption of a DOAC, there are studies that have shown that this interruption is associated with about 99% of patients having a DOAC level less than 50 nanograms per ml, which a number of clinicians feel is a safe threshold. So, this is something that we would allow thrombolytic therapy, for example, if a patient comes in who is taking a DOAC and has an acute ischemic stroke. And here are some data to support that involving the patients, just like the case I described. So this is the residual anticoagulant effect of the DOAC when measured just before the surgery and after 2 full days of interruption. And you'll see that the vast majority of patients have a level that is less than 30, which, by the way, means that it's not detectable. It's below the lower limit of detection of the assay. And then a very small number have a level between 30 and 50, which many of us consider not clinically important, but debatable, and then very few with a level over 50. So we try to provide an approach in the guideline that I've showed you from the American College of Chest Physicians that is a little bit easier for patients, simpler, 2 days off before, 2 days off after, that overall is associated with safe outcomes in terms of residual anticoagulant effect. And the third thing to note is that the DOAC levels when they're very low don't seem to be predictive of bleeding. So here are some additional data from the same studies that show that if you have a level that a DOAC level that is, let's say, between 30 to 50, it doesn't relate to a higher risk for bleeding than if the DOAC level is less than 30. And the same, even if the DOAC level is over 50, it doesn't confer an increased risk for perioperative bleeding. Now, the final point to note is that when you consider 2 days of interruption, 2 days doesn't mean, 24 hours plus 24 hours equals 48 hours. Rather, if we had our patient, let's say, is going to the operating room on this Friday at 8 o'clock, their last dose of the DOAC would be today, Tuesday, at 6 p.m. I know there's a time difference, so my apologies. But if you do the arithmetic and you calculate the interval from 6 p.m. on Tuesday to 8 a.m. or 9 a.m. on Friday, 2 full days off, that's an interval of 60 to 68 hours. And guess what? That is 5 elimination half-lives. So we're aligned, very much aligned with the anesthesia guidelines in that way. It's just, they're interpreting the half-life a little different. So coming back to that one other perioperative management principle, and this points to why we want to look at 2 days instead of 3 days, even though it might seem not that important, is that the approach that is common to each of these anticoagulants and antiplatelet drugs is to minimize the time that patients are off the drug so that we identify the shortest and at the same time the safest interruption interval. This is what we do for each of these drugs, and we should be doing it for the DOACs as well, using that little diagram to illustrate that we want the shortest possible interval off the drug to minimize risk for thromboembolism, but also that is safe so that we're not causing patients to have more bleeding. Now, here's a common what-if scenario that nowadays a lot of DOACs are being used for patients who have impaired renal function, and even some of them who are on dialysis. So here's a patient who has chronic renal disease with a creatinine clearance of between 50 to 20 ml per minute, and they're having a hernia repair. Are we going to use the same approach in terms of apixaban interruption? And, moreover, they've had a prior TIA 6 months ago. Now, we know from some of the larger studies that compared DOACs to the vitamin K antagonists, you'll see that in patients, if we look at the outcomes according to renal function, you'll see that the improvement, the benefit of the DOACs over the vitamin K antagonists is accentuated in patients with worsening renal function. So you'll see that the hazard ratio for stroke prevention is best in patients with impaired renal function. And you'll see also that the benefit in terms of reduction in intracranial hemorrhage and mortality is also better. But what's missing in these tables? What's missing is that we don't have data on patients who have a creatinine clearance less than 30 because these patients were excluded from these trials. But if we think about that trend, maybe in patients that have worsening renal function, the benefits of a DOAC will be even greater. So here are some studies that have suggested looking at DOACs or vitamin K antagonists in patients who have end-stage renal disease, and you'll see that there appears to be a reduction overall in stroke and a reduction overall in bleeding. So these are patients with renal function that is quite severe. How does this translate to perioperative management? Well, we didn't include these patients in previous studies, but I think it's sensible and it's supported by the guideline. And I go back to this guideline from the American Heart Association because what they've done differently is they've added a section on patients with impaired renal function with a creatinine clearance less than 30. And you'll see that in this situation, they're adding an extra day of interruption. So as we see DOACs being used more commonly in patients with impaired renal function, even severely impaired or even hemodialysis dependent, we probably want to extend the interruption interval because even though we don't have data in that population, I think it's very sensible to do that. All right. So we're going to switch gears and tackle the final scenario, which involves patients who are taking an antiplatelet drug, in this case, ASA. So here's a man with a prior stroke with a number of cardiovascular risk factors who needs an elective inguinal hernia repair. And the basic question is here, very simple. What do you do with the aspirin perioperatively? Do you continue or do you stop? Back to the American College of Chest Physician guidelines, what they are suggesting is that in patients who are taking aspirin and are having elective non-cardiac surgery, we suggest aspirin continuation rather than interruption. This is a weak or conditional recommendation based on moderate certainty of evidence. And it can be modified on a case-by-case basis, especially in patients having a high bleeding risk surgery. So in general, the default is not to interrupt, but you may want to interrupt in high bleeding risk patients. If you do interrupt, we suggest stopping less than 7 days, less than or equal to 7 days before the surgery or procedure. Now, you may think, well, why are you recommending to continue ASA? Wasn't there some large trials that suggested that we should stop aspirin perioperatively? So let's go back to the panel behind the scenes and what was the basis for this recommendation. I'm referring, of course, to the large landmark POISE-2 trial, which looked at aspirin use perioperatively for non-cardiac surgery. And in that study, patients were either randomly allocated to stop their aspirin or to continue it. And if they were not taking aspirin before, to start it or not take any aspirin. So there were two strata or two groups. However, even though this study showed that patients who are continuing aspirin, who are on aspirin had a higher risk for bleeding, there are two things that swayed the committee to recommend not to interrupt aspirin as the study might have suggested, but to continue it. And these two factors were this. The first was that about a third of the patients were taking an NSAID. And it was thought that if you take an NSAID, in addition to continuing aspirin, that might attenuate or minimize the antiplatelet effect of that aspirin to prevent cardiovascular outcomes. Because this study, the way it was designed, did not show an improvement in cardiovascular outcomes as had been hypothesized. But if you also consider the study according to whether a patient was already taking it, the aspirin, and then stopped or continued, you'll see that in that group, which is kind of reflective of the case I just described, there was no significant difference in bleeding. It was only bleeding was worse if you started aspirin preoperatively versus not taking it at all. So if you had been previously on it, stopped it, then the bleeding risk was not attenuated versus if you simply continued it. And the committee also found that there was data suggesting that continuing aspirin overall reduced thromboembolism. So once again, the default management would be recommended to continue aspirin, but there would be patients that you would move the needle in the other direction where you may want to stop the aspirin, especially, for example, if they are having a high bleeding risk procedure. Here's a table that kind of operationalizes this, not only for patients who have stable coronary disease, but in the scenario of patients who have a coronary stent. These are more complicated because they are typically receiving dual antiplatelet therapy, not just aspirin, but the addition of clopidogrel or ticagrelor. And in general, in these patients, we tend to continue the aspirin and then stop the clopidogrel and ticagrelor about 4 to 5 days before the planned surgery. And this provides a bit more of a more detailed approach. And these are types of patients that we may want to consult with the cardiologist because, when we talk about a coronary stent, there are many factors that leads to an estimate of thrombosis risk, the location of the stent, the number of stents, and so on. So it's always good to speak to a cardiologist about this. But as with warfarin or with DOACs, we need to have a pictorial representation. And this is an example of that, that you can refer to in the guidelines or other relevant review articles that inform when to resume the antiplatelet drug after the surgery, when to stop it according to each of the different drugs. I want to end by kind of looking into the future. And the future of anticoagulants appears to be factor XI inhibitors. And these are a newer class of anticoagulants that you might be a little bit familiar with. They're not yet available for clinical use, but they differ from the existing anticoagulants because what they are thought to do is that they may have protective properties to prevent thrombosis without increasing materially the risk for bleeding. And that is because factor XI is not really an essential component of the hemostatic pathway, but can be important in terms of amplifying a pathological thrombus. So, in many circumstances, for example, patients with congenital factor XI deficiency don't seem to have an increased risk for bleeding and may be protected from thrombosis. So a lot of research, many trials of over a couple 100,000 patients at least are being studied with these newer drugs. And why am I mentioning this? Well, I'm mentioning it because perioperative management will be an important consideration for these patients. And if you just look at one small study that looked at perioperative management of patients who are receiving these newer drugs, you will see that their rate of bleeding was very low compared to a direct oral anticoagulant, so even lower numerically, which suggests that these patients may also may not need to have these drugs interrupted around the time of surgery. And this is important because a lot of these drugs have very long half-lives. You'll see that for the drug that I just referred to here, the abelacimab, it has a half-life of not 20 to 30 hours, but 20 to 30 days. But that won't probably matter because even if we continue this drug, it does not appear that they are at increased risk for bleeding. Some of the other drugs, the smaller molecules, have shorter half-lives, and you may have heard of molecules like asundexian or milvexian. So this is more toward the future for you to stay tuned, and hopefully these drugs will be available for clinical use in the coming years. So I'd like to finish off by going back to the learning objectives. I hope that the presentation and the material associated with it will help you in managing patients who are on a vitamin K antagonist or who are on a direct oral anticoagulant and require elective surgery, and in selected patients who are taking an antiplatelet drug. I've just covered a few key areas, but I urge you to look at other resources. Overall, though, what has changed in the last 10 years is that we are using less heparin bridging. We are continuing ASA more, and we have developed safe protocols for DOACs in terms of their interruption and their resumption after surgery. So I referred earlier to the McMaster textbook of internal medicine. This is the English edition, and this is the Ukrainian edition. And hopefully you might want to have a look at this because it covers pretty well all of the material I've covered herein. And then finally, here is the access point for that. If you want to just click on that and access this. And with that, I want to also bring your attention to the McMaster Internal Medicine Review course, which is happening this May in Krakow, Poland, and something that you might consider attending either in person or virtually. I know that you will find it an outstanding meeting, and hopefully it's not too far geographically from where you are. It also provides opportunities for emerging clinicians, young talents with a case report contest. So please check this out if you have an opportunity. With that, I'd like to thank you very much. Dziękujemy za uwagę, and I hope you enjoyed this presentation, and I'm happy to try to address any questions or comments that you may have. Thank you very much.